Two of talking about endometriosis during Gut Love Grand Rounds. I'm not sure what happened there, but we got kicked off quite unpredictably. So let me bring back Dr. Goldstein. I'm not sure what happened. So let's see. Sorry about that. I'm not sure what happened.
I
I don't know what happened.
It must have been this uterine model cracked the internet.
That's it. It couldn't handle it. Couldn't handle all this knowledge.
Yeah. So basically, it can be like having mini periods all over. And
Crazy.
what happens is those other lesions where they are, they're not shed like the endometrial lining. So when you have cramping in your uterus and you get rid of that blood and lining, people think, oh, the cramping may get better, the bleeding is gone, then I feel better, right?
Yeah.
Unfortunately, all these other locations of disease, they don't get rid of them. It doesn't shed. And even being on birth control and hormone control and Lupron and all these suppressive therapies,
Yeah.
it doesn't get rid of those lesions either. It doesn't get rid of the disease. It just sort of suppresses them. And
Yeah.
so that's why this disease can linger around. If it's not properly found and removed, it can sit there and continue to cause symptoms as long as they're in there.
Yeah.
So
yeah, I mean, and what you mentioned also in the beginning of, of what you're saying about the gaslighting, right? Because like people are having all these symptoms. We'll talk about only a very specific way to obviously find these symptoms. Sometimes it can be, or find the root cause, and it can be very hard. So people are going from doctor to doctor. It's in your head, or, right? Like there's so much gaslighting, and it takes, I mean, how many years to usually get a diagnosis
usually
of endo?
8 to 10 years.
8 to 10 years. I mean,
Yeah.
that's a, it's a frightening number
Yeah.
that someone
Yeah.
is going through years and years of all this suffering, and it can be so debilitating, right? Until they get a real answer.
It can.
So,
And there's also not only debilitating, but one of the really frustrating things too for a lot of patients is it's one of the main causes of infertility. It causes 50% of unexplained infertility. So I actually see a lot of patients, and I'm quite passionate about that, is that infertility patients who are never told anything about endometriosis, not once. They've gone through years and years of IVF, years of miscarriages, years of failed embryo transfers, years of failed IUIs. They've spent so much money and time and heartache and loss, and they're never told endometriosis. And they're never offered a diagnosis or to look it up or see if that's a part of why they're having infertility. And so to me, that's maddening, right? IVF has come a long way. It's great. I know some fantastic IVF doctors, but we need to do our service to the patients that this might be on the table, and patients with asymptomatic endometriosis and infertility is their main symptom, and they may not have any other symptom. I did a case last week. It took my portion took 6 hours. The cardiothoracic surgeon another couple hours. The patient had stage 4 disease, seeding the diaphragm, the liver herniated through the diaphragm into the chest cavity, bowel disease, the ovaries frozen together, the bowel fused to the back of the uterus, stage 4 endometriosis, both kidneys blocked, the ureters dilated, a mess. And this patient had been through a recent embryo transfer 2 weeks before with a lung collapse and kidneys dilated, and, at a major hospital in New York, multiple rounds of IVF. And, they knew that it was there and documented it and saw it in imaging, and not the lung collapse, but everything else. And I mean, this is, it's very upsetting to put people into even a pregnancy at that state and to continue to bombard them with tons of estrogen of IVF. When the pelvis is in that kind of state, how can you imagine that an embryo can survive in that mess, and the mom can be safe, right? And the patient can be safe. And so I'm really also sort of passionate about cases like that, where I just feel like the patients deserve better,
Absolutely. Wow. Yeah. And that's interesting in that they're using these patients are getting estrogen, because in general, endometriosis is considered like a chronic estrogen driven inflammatory condition, right? I think a lot of people don't realize, you know, what you just described when you open up someone's, you know, thoracic, abdominal, pelvic cavity, and it's like there's adhesions, there's the right, like, I mean, you know, it's not just these
Yeah.
discrete little lesions.
No.
And so I think that, you know, we'll talk about like the connection with some of the gut issues, because of course, endo is very commonly, it's like around, I believe, a third of patients will have a disease involving the bowel. And in most cases, it's the rectosigmoid area, right? The very, very
Yeah.
end of the bowel, which, you know, again, creates a ton of pelvic floor issues, evacuation issues, motility issues,
Yeah.
dysbiosis, all those things. But, you know, in a lot of, you know, people also, like, we see that they go to surgery and they have adhesion. So it might not even be that the endo is on the bowel
Right.
all the time,
Right.
but there's just so much inflammation in the cavity
Yes.
that you see, right?
Absolutely. And even with the appendix and the cecum, sometimes the small bowel is a little bit more rare, but people certainly have small bowel disease.
Yeah.
But we quite commonly see the appendix involved, or I'll see a lot of like periappendiceal adhesions, and the adhesions have taken the appendix down right near the ovary, or sometimes the appendix is even attached to the uterus. And, you know, it may not come back endometriosis, but it will come back adhesions, fibrosis, something, inflammation of the tip.
Inflammation, yeah.
And so just like you said, and I always tell them, like, we don't know if it was like an appendicitis that healed that your body tried to take care of, or if it was endo that attracted this, that, you know, that was a perfect combination.
Yeah.
But frequently it's involved, and it creates a lot of, you know, gas, bloating, nausea, right-sided pain, you know, and symptoms where they may work for a long time, you know, with GI doctors like yourself, and then they're not getting results, and then there may be something like this happening. And so for me, it's fascinating to collaborate. Like with you, it's great because it really helps, you know, to have resources back and forth, even when we do endo surgery and then bloating is still present. You know, then there's still, I like to say, like, I'm not a magician at all, right? I'm a surgeon. I technically can remove the disease, but it's still so important what we put in our bodies and how we exercise and what we do with our minds. And that really is still important for your whole care in life, right? And so even if we remove all of this endometriosis and the bowel is clean, then it still takes a lot of work. And if there is not full results after removing all of the endo and the scar tissue and the disease, then I think it's really important and awesome to integrate between GI doctors, nutritionists, you know, all different modalities to really get people feeling their best before surgery, after surgery, anytime, even if they don't have surgery, right?
Yeah, absolutely. And we have a couple questions to go through, but I was wondering if you could also just talk about, you know, because a lot of people do go through, you know, they'll get an ultrasound. The ultrasound is normal, right? Then you go to an MRI.
Yeah.
And an MRI, right? Even if you're going to your favorite radiology, you know, hub and
Maybe
getting
normal.
all the
Yeah.
MRI.
Yeah.
So, you know, so it's really hard, right? Like, I mean, can you just talk quickly about the stages, right? And kind of like the thoughts on diagnosis that could help some people.
Sure. So a lot of endometriosis that I see in early stages, so stage 1, stage 2, may not show up on any imaging. It may not show up on the ultrasound or the MRI. Why do I still do the imaging, right? I always do my own ultrasound in the office when I see patients in person. I like to see the direction of the uterus, how it's tilted, where it's pressing, if the uterus is severely tilted and sitting right on top of the rectum, and that's really tender for them. You know, all of those things are really important for me when I examine a patient. And then I do MRIs because they actually look at the bowels, they look at the kidneys, they catch things like this, like kidney back pressure or hydronephrosis.
Yep.
If there's deep nodularity involving the bowel wall, they will pick it up on MRI most of the time. And so it will help me set up the situation that I know ahead of time. Okay, I need this team, that team, colorectal surgeon, this urologist there that day. You know, it helps me coordinate their care for their surgery day and the teams. I always have those teams on standby, but when you know you're going to need them for 4 hours, you need to tell them ahead of time, you know, so it's a nice thing to do. So the MRI is really important, and uterine anomalies we can see better on MRI. So uterus with 2 cavities, uterus with only 1 cavity, uterus with abnormality, that will be more likely to cause endometriosis, any kind of Mullerian anomaly, as we call it. And so those are picked up on MRI. We could also see adenomyosis, another disease involving the uterus that's very similar to endometriosis. We can see that on MRI. And so it's still important to do these, and we're able to rule out or rule in other things. And even if the MRI is negative, the patient doesn't have to get upset. It doesn't mean that there's not endo. It just means that the lesions are not 5 millimeter in depth or more. Most endometriosis, early stages, and probably 80% of the disease is really a couple millimeters in depth. And so it won't pick up on these imaging. It doesn't mean it's not there. And it doesn't ever mean that I don't believe the patient, right? I still take a meticulous history and read through all of their history that they've been through their whole life and what's been happening and when their first period was and if that was painful, when they started feeling bloated, when they started getting constipated, if they missed school, what happened when they were a teen, like how was college, when were they first thrown a birth control pill, what happened when they went on it. Like I go through an exhaustive thing, and how is their bowel, how is their bladder work, if they're peeing at night, how's their bowel movements, are they going every day, are they having rectal pain, are they having rectal bleeding, are they getting bloated after they eat, does that coincide with the period, are they having constipation with ovulation and then loose stool with their period, rectal pain on their period and trouble position changes to empty the bowel, that could mean adhesions around the rectum or a rectal nodule. Painful sex is a big one, painful intercourse. Painful exam at the OBGYN's office. There's lots of little clues and things, and then other systemic autoimmune disease, GI diagnoses like IBS or Crohn's, but then they're not getting better with the therapies. SIBO, but then they're not getting better with the treatments. All of these things, and I'll take into all of that in account. And, when several of them are positive, or their fertility history, miscarriages, loss, any kind of pregnancy complication, those can also be significant with endometriosis. So family history, mothers, sisters, cousins, those that have them. So I look at all these things, and then that sort of paints a picture of where the disease may be sitting, if they have chest pain, if they have back pain, leg pain, when it happens, and if these things correlate with hormone surges. It does not have to be just pain with the period. Many endo patients don't have painful periods. They have so many bowel symptoms, or pain with ovulation, or leg pain, or back pain, or other things. And it doesn't mean it's not endo. It just means the location may be in a different place from the uterus itself, So.
Yeah, it's kind of like we learned in med school, right? It's like the history, like if you actually sit down and talk to a patient for a long enough time, which unfortunately in most cases working in a health system, you don't get that time, right? But if you can really talk to someone, like you can find out all of, it's amazing. You probably like are so confident after hearing, a history like that, like whether or not they really truly have endo.
Right.
So let's jump into some of these questions. And I thought this one was really interesting for you about menopause. What happens after menopause with endo?
Yeah, that's a great question. So, and it is a question, right? So some patients with endometriosis in menopause, and even if they don't have the endometriosis removed, they may do fantastic in menopause, and it doesn't really bother them anymore, as long as they're not doing unopposed estrogen hormone replacement. So if an endometriosis patient still has lesions there or disease in the uterus, and then they're just given an estrogen patch when they go into menopause, guess what? Just like we talked about earlier, it's estrogen sensitive disease, progesterone resistant. So in a very tiny print on the recommendations on how to treat menopause patients, the ACOG guidelines, there's like a very tiny print at the bottom that's like, think twice in endometriosis patients before giving them unopposed estrogen, right? But it's like a very small print, and people don't talk about it all the time. And we want to be protective, right? So if you're giving estrogen to an endo patient, they should be on progesterone as well. It should be balanced, And I see a lot of patients in perimenopause, menopause, endo patients who have had menopause early, their ovaries out early, and I'll treat them from young ages. And I still do a very balanced hormone approach with them. And if they need testosterone, DHEA, thyroid, we look at everything, and we make sure that their vitamin levels are good, their B12, their D. Like I like to overall just make sure clean bill of health and we're doing well, especially because these patients are more susceptible to go into menopause earlier than the general population,
Sure. And you just mentioned, nutritional status and looking at some of those things. And another question had come in about the connection between SIBO, right, and gut issues and endo, and then like what to treat first. And I think, it's kind of interesting because we see this a lot with SIBO in general, right? SIBO is, even though it's a it's a root cause that when you treat it, people's symptoms get so much better, but it's still due to something else, right?
Yeah.
Like
Yeah.
something is driving the SIBO. So, you know, and I know we've shared some patients already, and I'm sure you've had a long experience of this. Like when you actually do the excisional surgery, when you get rid of the endo, I mean, that's when that recurrent SIBO stops,
Mhm.
right?
Yeah. Yeah, hopefully so.
Yeah.
And I mean, you and I have talked a lot about, these studies about the most hydrogen being produced in the appendix.
Mm-hmm.
And, it's always a great question. There's a lot of discussion in the endo world for endosurgeons that, do we take out everyone's appendix? Do you go across the board? When they've done studies on this, and every patient that they took to surgery for endometriosis had their appendix out, 30% were abnormal.
Mm-hmm.
And so that's huge, right? So,
Yep.
I don't do it on everyone across the board, especially if they want to retain their
Yep.
appendix or something. But certainly if they've had failed SIBO treatment and there's inflammation or adhesions around it, or it looks at all funny looking,
Mm-hmm.
then, I will take it. And a lot of patients, SIBO does get better. Some still have resistance or recurrence of it,
Sure.
and then I obviously always like to collaborate with you, or, and have a whole team for them afterwards,
Mm-hmm.
that if that's happening, then like you said, we're trying to get back to nutritional causes. And then you're going to do work with them on prebiotics, probiotics, and this fascinating stuff where, we don't just slap a general supplement on everyone. We like think about what we're doing and what they really need. And I think that's really fascinating too. For me, I want to hear more about from you, is all the prebiotic and probiotic strains and how people's gut, produces different things. And in our life and in our hormone pathway, everything changes. Our hair changes, our skin changes.
Yep.
And we know that you probably go through so many different strains with the flora. So I think that's really exciting work too, that,
Yeah, I think, yeah, SIBO, as people asked, a bunch of SIBO questions came in, like that's only one part of dysbiosis, right? That can be
Mhm.
associated with endo. And again, we talked about, like the issues with adhesions, motility, right? Because of the actual implants, but even because of the adhesions and the different inflammatory kind of milieu of the abdominal cavity, right? There are a lot of reasons you can have dysbiosis. And so SIBO is just one type. But in all the other, studies, like they've shown in endo patients that there is, the microbiome is a part of the disease. And we'll see, like, as we learn more, because again, the origins are so still kind of hotly contested about, is it bacterial? Is it, like, what is it, right?
Mhm.
And I know that there's even like moves to treat, endo with more like antibiotics, right? In some,
Yeah.
some thoughts. So in some camps. So, I think that again, there's a big base of like a microbial dysfunction in endo. And so
Mhm.
specifically studies have shown like decreased diversity, I would say, is kind of like the
Mhm.
most common thing that comes up. The other thing is a decrease in the short chain fatty acid producers, right? So
Mhm.
the specific bugs in the microbiome that are producing the anti-inflammatory compounds like
Yeah.
butyrate and acetate and propionate and all those things that have anti-inflammatory,
Properties.
effects around the whole body.
Yeah.
Right. And really fascinating is there was a study that showed that when you are treating endo, like when you treat endo with like hormones and you get some of
Mhm.
that, you re-regulate and kind of balance everything, that actually like then those short chain fatty acid producers go up and short chain fatty acids go up.
Yeah.
And so like they're so tightly connected. And, again, we know that there's regulation of estrogen in the gut
Mhm.
with
Yeah.
certain enzymes,
Yeah.
right? So again, like this dysbiosis can be driving people's ability to have higher or level, higher or lower amounts of estrogen. So there's so many ways with endo that you can, really think about what's going on in the gut. Someone just said, but what if you can't absorb and metabolize the butyrate supplement? Because a lot of people, butyrate as its own supplement has become a really hot kind of a hot item
Mhm.
because it's been shown to do so many things. It literally is the energy. It drives like the life of the colonocytes, the colon cells.
Mhm.
But it also does things like in Parkinson's, it's been shown to decrease like the motor symptoms. Like it does so
Right.
many things, right?
Right.
And so again, and definitely there's some kind of anti-inflammatory relationship with endo. So some people take butyrate. That's kind of, there's a little bit of a question of how much butyrate, if you just take it orally, is actually going to be like absorbed and work like your body's own butyrate.
Right.
It's definitely an evolving topic, but the key is, again, to work on actually increasing your butyrate producers in your
In your own
microbiome,
body. Yeah.
right? And then you're making your own natural butyrate. So let's see. So going back to, so again, I think that there's so many different kind of, just so many different pathways to go down in the microbiome sphere in someone who does have endo. So whether they want to do microbiome testing, SIBO testing, like all these things could help, going a more individualized approach, because
Right.
we know there's a connection.
Yeah.
So someone, going back to the questions, because we don't have too much time, I could talk to you forever. Someone said, if you have SIBO, would that affect getting a lap, like a laparoscopic surgery for endo? Does anyone see that as a red flag? No. Yeah.
No.
I don't see that. I don't, SIBO is something where people go into pregnancy with SIBO and have no problems. Like, yeah, SIBO is a local, issue with, definitely with digestion and absorption of, nutrients and some motility issues, and like, people can have leaky gut, but as far as surgery is concerned, I can't imagine there's any red flag.
Yeah.
Someone said, what if you do surgery, but constipation doesn't change?
Yeah. And that's a good one. And that happens a lot, right? And so I always have to look back at everything environmentally and all the medications the patient's taking, right?
Yeah.
And even before I do surgery, I look at a lot of medications that may slow down motility, right? And so a lot of anti-anxiety, antidepressants can really slow the bowel down, slow the bladder down. They can cause you to retain urine and feel like you have a UTI all the time. So, I mean, I really look back at all the medications someone's taking, and they may even be taking something for headaches or something random, and they don't realize, or they're not really explained what the side effects are. So first I'll look at everything they're intaking, what are the medications, if they're on any meds, and if they're not on meds, what is the history there? Have they always had constipation since they were a baby or a little kid? Their mom used to tell them about it. What was their normal every couple days or not? I'll look at emptying, and if they're using like poop stools or they're having trouble actually evacuating, and what is the quality of, I do ask a lot of like poop questions to patients, but it's important.
Most important
and
questions.
It's important for the evacuation and overall how they're feeling and how they're digesting things, right? And so if their normal is like every other day, but it's easy to pass and it's not a big deal, fine. But if their normal is 3 or 4 days and they've sometimes had week to 10 days and impaction and different things like that, then we really have to go through everything. And, sometimes surgically, I can actually see things like redundant sigmoid or where, they'll actually have really long rectosigmoid colon, and it seems like it's all looped down in the pelvis where it's not really supposed to be, and you can tell that it would just take like a really long time for anything to get through. And I'll find anatomical things, but I may not always see that, and so if not, then obviously I like to work together, and find out if they've had like gut motility studies, and then what they're doing in their life, what they're putting in their body food wise, drinking wise, and supplement wise, fiber wise, and how that's affecting it. And if it's helping, we can go through all sorts of things with fibers and magnesiums and all different things that, may help them or doesn't help them. And so I always try to see environmentally, like everything they're putting in and everything they've tried and what we haven't. And then sort of work together with specialists like you, with nutritionists, even sometimes pelvic floor therapy. After surgery, they may have a lot of tension in the pelvis from chronic pain and chronic endo, and then they're actually holding the pelvis really tight all the time subconsciously. And then they can do down regulation work to actually be able to evacuate and poop easier and, reduce some of their tension and back pain and lower pelvic pain. And so there's a lot of different multimodal ways to help this and help the patients aside from just surgery. And I think that's what I'm really passionate about too, is that, while I am a surgeon, I was a patient first, right? And I went through my whole 20s having colonoscopies and doing all this stuff and trying to get to the root cause and trying to try every sort of diet and all these things. And so I think that's really important that it's, for me, I always had to have a whole team of collaboration and go to acupuncture and try different things. And you know, and so I try to like always incorporate that and think back to that for the patient too, is that, you know, those things are always important. And it's not, there's no one bill, just like you see with your patients, there's not like one recipe for all endo patients that works,
Mm-hmm.
right? And everyone is totally unique. And
Yeah.
so, and everyone has something different they put in their system, and then how they were raised and what they've been through and what they've been through surgically. And so there's always, you have to sort of piece all of these things together. It's not like a one size fits all at all, you know?
Yeah, no, you're right. And you bring up two really important points, I think. Like, so for a lot of these patients, they've been, again, going through seeing gastroenterologists, and everybody else probably got put on amitriptyline and
Mm,
who knows what other
I love that one.
SNRI,
The
SSRI.
depressed bowel, I think, you know, it's like,
Right, just like you were saying. And then like, so again, like constipation after surgery, it's so true that, because then like you've been put on at some point, probably didn't help you too much, but you're, you know, continue on it because you're hoping it would help. And
right,
then you have to keep reassessing, especially when you get the surgery. Like, okay, well, I was probably put on that
right,
before because I didn't get to my root cause, and now it's probably contributing to constipation. And the
right.
other thing that you mentioned, absolutely, which is so key, is the structural, right? Like the structure of the colon, which, you know, you were describing that super redundant, you know, rectosigmoid area, which is, you know, so hard to scope, right?
Yeah.
And so like, as I'm always kind of scoping through that area, I'm like, wow, like it must be so hard to get stool out. So true, right? All
Right.
the gas trapping, all the
Yeah.
curves.
Yeah.
And so it's actually interesting how much, you know, your procedure could even shine a light on, and you know, further anatomic issues
Mm-hmm.
that could be affecting people again. So it might not be 100% the
Right.
endo could definitely be a part of it. But
Yeah.
then, you know, there are these things, or people who have been constipated for years because of endo, and then
Mm-hmm.
their colon has become like a little wider,
A
a
little,
little more
yeah, a little
tortuous.
lazy. Yeah.
Yeah.
And you see with chronic constipation, the rectum's dilated,
Yeah.
right? And then even when, or the rectocele, but then chronic constipation and difficulty emptying, then it's actually structural at that point too. Then it's also difficult to get around that. And you can't just do fiber, you know, when the rectum is dilated like this big and it's supposed to be this big, you know? And
Right.
so, yeah,
Right.
there's a lot of sort of factors playing into it, you know? But.
Okay, we're going to do one more question because I want to be very respectful of your time. There are just, again, so many things that people have asked, but I guess one question is, outside of the surgery, again, if you're thinking about food, hormones, acupuncture,
Mhm.
you know, are there things that, you know, you really like to incorporate into care as far as, you know, those things go, and then things to avoid?
Yeah. So I think in general, food wise and life wise, you know, most patients will really respond to lower inflammation.
Mm-hmm.
And because endometriosis really goes hand in hand with
Mm-hmm.
inflammation, it's very important to try to incorporate things that can try to lower inflammation. So
Mm-hmm.
systemically, you know, and it's very difficult in the US, as we know. But I like to say for, you know, really try to lessen preservatives, sugars, added sugars, artificial sweeteners, colorings, all these things that can be irritative and allergy sources can be very
Yeah.
pro-inflammatory. And so most patients don't respond well to them, right? Gluten is a big one. You know, a lot of patients, dairy, meat, it really depends on the patients, and everyone, again, is unique, right?
Yep.
Some endo patients don't respond well even if they're vegan. They may not respond to plant-based, and they can't do a lot of raw foods. It's really hard on their gut. And
Mm-hmm.
so there is not a like perfect, again, scorecard for everyone to follow, but
Yeah.
I would say that everyone does benefit from less preservatives, less gluten, less sugar and additives and processed foods that are in the US, right? And so those things, if you can stick to farmers markets if they're available, the outside of the grocery store where it's all the fresh fruits and vegetables, you know, even if you're doing protein sources, meats only a few times a month, grass fed, like local wild fish, high, you know, black cod, really high quality fatty acids in the fish.
Mm-hmm.
And then working with nutritionists. I mean, I work with some great ones too that work with insurance, and they go through what they're deficient in and food allergy testing and sensitivities. And they may only need to do that short term, but it may really help their symptoms,
Yep.
right? And I tell patients, even if we, you know, I can't stay plant-based all the time and do all this, I try like morning and lunch. I worked a lot with a friend, Jessica Murnane, who's fabulous, who did this book, One Part Plant. And it's like, try to just do one meal a day of veggie based and then build from there and see how you feel. And I think that's very approachable, right? And I suggest that with endo patients too, is try to eat this way most of the time. And then even if you can't all the time, it's okay. But if you go to a party and you have pizza and Coca-Cola and alcohol and birthday cake and gluten and whatever, know that that next period or that next few days may be more trouble with your gut, right? And so be sensitive to that. Okay, I'm going to go out this weekend. I'll have the cake, but I'm going to skip out on the rest of the stuff and pre-eat at home or do the healthier choices there. And then, so it's sort of like a balance effect, right? And particularly the week before the period, if the period is very painful, to cut down on the inflammatory foods the week before will usually make a better period. I see a lot worse periods after the holidays and more pain pickup. And I think that's because the systemic inflammation and the inflammatory factors are higher then. And so you can sort of help yourself plan if you think about it that way with life. So, you know, when the period's coming up and you know things are going to get bad, then reduce the level of inflammation, hydrate well, try more yoga, walking outside, taking fresh air, like doing all these things to help get your body ready for that situation. In the same way that I would say for patients with infertility and approaching a pregnancy, the same kind of ideals, you know, so.
Interesting. Yeah, no, I like that you know, can kind of have a roadmap for, you know, changing your diet to improve your periods and pain around periods. I think that could help a lot of women for sure. You know, one last question that came up, someone had asked this before, and, you know, because we're talking about inflammation, how it's you know, there is so much inflammation, you know, associated with endo. Is there a blood marker? Like, do you ever see CRP that correlates? Is there anything you think could be a hint, like a marker?
They're working on it. So CRP can be up, but it's not always up. So it's sort of like with endo, that's the problem, is that we do CA-125. It's a marker for ovarian cancer, but in endometriosis, it can be slightly elevated. But not all endo has it elevated, right? It will be elevated in big endometrioma, chocolate cysts of the ovaries, really bad uterine disease, adenomyosis, that will be up. So it will give us a clue, but it may not catch all the stage 1, 2, and some of the 3 diseases, you know? And so, and then CRP, it's a good question. Some of them I will see elevated, but if I do them across the board, it won't all be elevated. And so it's hard to, so I don't do like blanket testing like that. I will include the CA-125 on all my, and I typically will do, you know, imaging and workup before an MRI, hormone panel with some vitamins and a CA-125. So I'll include all those on there. I don't typically put a CRP because, again, it's really varying on patients, and I haven't found it to be across the board useful. Even if their pelvis is a mess, you know, then sometimes it doesn't always correlate. So, but hopefully soon. They're working on it. You know, there's a lot of attacks with endometriosis right now, working from endometrial biopsies, blood tests. They're really trying. There's all kinds of research happening across the world right now to try to find a test, or I think what it's going to be is maybe a combination of tests, a blood test, uterine biopsy. Like it'll be like a packet of 5 or 6 different tests, and then you pull them together maybe, you know, but right now there's sort of a lot of different research groups. Each one's working on that little test, right? And so sometimes they have conferences and band them together, but that's really what would be cool, is if there was like an endo diagnosis kit that really combined all of them. And then, you know, maybe one of them will be positive. There's some for fertility that they're doing BCL6 testing inside the uterus and integrins. And, you know, they can be positive in endometriosis patients with infertility. Bruce Leslie, his lab is doing it. So, I mean, there's some movement in a lot of different ways for pre-diagnosis before surgery. And so that's great. And hopefully one day, you know, we'll have better way to do that, you know, but right now it's sort of like combining everything. And then even if they're all negative, listening to the patient, you know.
And maybe we should do this like once a year, and we'll catch up on, you know, all the progress.
Absolutely.
Hopefully that's coming out, because a lot of different fields are moving towards this less invasive blood biopsies, right? All of these things that can tell us a lot of information, so that when you go into surgery, you're better equipped and kind of understand what you're getting into. So hopefully soon.
And I think it's so important for patients, like before and after, and even if they never have surgery, I think all of these things are so important. And it's okay. Like, even if you're trying and working really hard and incorporating this stuff in your life, like I always tell them, like, it's going to make you a healthier person in the long run either way. And so
Yeah.
even though you may have a bad gift of endo, right? Hopefully you're already on top of it, working so hard to do all these things and incorporating these great things in your life that you'll be awesome later, and you'll be able to handle things a little bit differently than someone that's just, eating McDonald's every day or doing whatever they want or something. And so it's like when you have these things and you have to adjust the way you do things, then overall hopefully it affects your outtake and ability to handle everything later. So.
Absolutely. Absolutely. Well, Dr. Karli Goldstein, thank you so much for joining us. You're such a wealth of information. I think that we could probably spend hours answering all the questions, and we should all definitely do this again, at least like once a year. I hope everyone follows you on Patient Surgeon Mama, right? Mm-hmm. And you post the most interesting, reels about, again, like, these cases where it's in the thoracic cavity. Really interesting. I think that, like, if you are looking for your root cause, if you're still trying to understand like what is going on with you, like, get information, like, understand other people's journeys, right? And that's what you get with your Instagram. You hear these really fascinating cases, and I think it can help other people learn about their.
Someone said, I don't know about the OR picture and then the tuna fish right afterwards, and I was like, oh, I didn't even think about that. I was just like, I'm just like, day in the life. This is me doing surgery. Now I'm in the doctor's lounge. Oh, the only choice that's healthy is maybe, sort of, is tuna fish.
Yeah,
I was like, I was just like, this is my like day of what's happening. It's like there's something about eating bad tuna fish in a physician's lounge that's just sort of like ingrained in me as a surgeon, that we just do that, and like that's like and I'm like, but anyway, I was like, oh yeah, I didn't really put that two together. I wasn't even thinking of it that way. I'm like, wow, it's
so true. It's just a day in the life. That is your normal. Just go in between.
Yeah, exactly.
Love it. So, well, thank you so much again, and
having me.
Thank you.
Have a great weekend.
Right. You too. Take care. Bye.